that's you, I think.
So the case I'm presenting today is that of a 26-year-old woman who was first referred to Professor Yannicus approximately a year ago with a 3-month history of involuntary movements involving the right hand. The movements were associated with cramping and twitching. She had no other associated neurological symptoms, in particular no sensory symptoms, and no involuntary movements of the neck or tremor. She had been previously well, and there were no obvious precipitating factors to her symptoms, although she was 18 weeks pregnant at the time. Her background was significant for writer's cramp in the same limb in her teenage years. She also had asthma and was on a serotype inhaler. She was married, 18 weeks pregnant, non-smoker, didn't drink any alcohol, and there was no family history of any neurological disorders. Her physical examination was most remarkable for the involuntary movements involving the right upper limb, and I'll show you a video of that shortly. She had normal tone, power and reflexes throughout without any muscle atrophy. The sensory examination revealed some variable reduction of pinprick sensation in the right hand, but was otherwise normal. No.
This isn't the Movement Disorder Society meeting, is it? How long have you had this thing?
4 months. Might stop it there.
So, do we have any comments? Steve? What would you say about the movements?
Clearly, I can get irregular jerky movements, then I've heard it called hearing at rest. If I was in a movement disorder meeting, I'd say, well, it's probably a bit of chorioathetosis. But we're not, so I'm not going to say that. It looks as though there are sort of some clinical myochymic elements in the APB. And clearly her movements, the movement of that hand is impaired. There's some muscle atrophy that I think there is some either real atrophy or pseudo atrophy that I can see from there. I don't know, was she weak in that hand?
No.
No, so fairly strong, was she? So the next step, I'd like to do some nerve conduction studies and EMG.
Well, before we get to that, Carolyn, what would you say about the movements? You're the doubling up for the movement disorders representative here.
I think that's right. Thanks. I mean, they were irregular movements. They weren't brief and shock-like movements, so they were unpredictable. I guess I'm just trying to think why I don't think it was chorioathetosis, but it looked different. To me, it looked like there was some contraction of the muscles, and some excitability, I guess, of the muscles or the nerves, I guess. So they were unpredictable, they were variable in amplitude and in action and in direction, I guess. So I guess that's why I don't think that they were chorioathetosis, they were less predictable than that. I couldn't see any fasciculations, but I don't know whether you can
There were
exclude
no
that on
obvious
video.
fasciculations,
Yeah.
unless, yeah.
And I guess that's why I was asking you whether she was trying to contract those muscles or not as an action. But if they were doing it at rest, then I would have thought they were an excitability type of phenomenon.
So, do you think that she had writer's cramp as a
No.
teenager has any relevance to this? Is this dystonia?
Could this be dystonia? No. Did she have writer's cramp as a child? I mean, so she did. Is that what you're saying?
She had writer's cramp
writer's cramp.
as a teenager.
Right. Okay. Well, could we see that? Did you film her writing so that we could see, or has she moved on?
Well, she
from
couldn't
that?
write because her hand was continually.
Yeah. So this might be a constant writhing movement. It's too slow for my arrhythmia. I don't think it's dystonic. I didn't see you testing for dystonia here.
Okay. No.
So I can't comment on the dystonia, I'm sorry.
So any other comments as to what people think this, Liz? Joint position sense was normal. Yep. Yep. What were you thinking of, Liz? Pseudoathetosis? So any
Was this going on all the time, Con? I mean, it'd be very hard to test the power at all. You know, since you've got normal power, but how can you possibly test power in someone who's...
look, it fluctuated. Like when you saw when she had her hand down, she could actually, it wasn't as bad as when she had her hand in posture. So you could actually test her power to the best of
I think
your,
it'd be very hard to test power.
to be sure.
And you'd even have to wonder about whether that was some motor epileptic phenomenon. You know? I mean, it's just something I'd say I've never ever seen in my life. Very peculiar
Okay.
appearance.
So what test would you want next?
What about a reflexes? What were they like? I think you said that, didn't you? And then there's this history of writer's cramp. What was that story?
Well, she said she had writer's cramp, some difficulty with writing at school. So it was impossible to test her writing with her hand.
That was because of these kind of movements?
No, nothing like that. She just she gripped her pen very hard at school and it slowed up. It was nothing like this. This came on during her pregnancy. And it was there all the time. Sean?
It's such a weird movement. When her hand was outstretched, it seemed to have this very kind of rhythmic kind of pattern that started with flexion and then went into extension for the whole hand and seemed to involve kind of multiple nerves. And I guess I'd wonder if it's something coming from the spinal cord.
So MRI spine was normal. Yeah. So did you think the movements were segmented when she had her hand flat? So the sort of thumb and the index finger were going first, and then the others would follow, and then it would go into a grip. Okay, so
The video, yeah. I think she's straightening.
she's trying
it
to
out.
straighten it. Yeah. No. She's trying to sort of straighten it. It's flexing. It's actively flexing. No.
Is there any family history of any neuromuscular disorder? Is there any consanguinity?
So the thumb abducts on its own quite a bit. And the finger flexes, the thumb flexes I should say, then the index finger flexes and then the other fingers go.
A lot of the muscle movements are incentive in that CAT1
How long have you had this thing?
Given the sort of the erratic amplitude and rhythm of the movements, one might consider that myotonia a segmental myotonia with short rate PCC with the CAT1 proximal nerve lesion might flow hypothalamus.
Okay. So do you want electrophysiology or?
Can I ask what you were thinking when you saw that? Have you ever seen anything like it before yourself?
Well, I actually have.
I don't want to talk and talk, but yeah,
I'd seen it once before.
But again, just there, these to me look like there's a regular and repetitive pace, but the frequency is irregular.
It's irregular, but it starts off with the thumb and then the index finger and then the other fingers go and then it gets into a complete sort of,
In a sense, it's stereotyped, even though it's an irregular
yeah, the same movements are occurring, but it's not they're not all going at the same time. Yeah. Okay. So do you want some neurophysiology?
So preliminary investigations, including imaging, were normal.
Anticardiolipin I just did just in case she had anticardiolipin syndrome and pregnancy-related chorea because she was pregnant, but it didn't look like chorea.
So moving on to her neurophysiology, the median sensory studies were normal and symmetrical, as were the ulnar snaps. Similarly, her palmar, median and ulnar palmar studies were normal. So the significant finding was on the motor study of the right median nerve, which had a normal distal motor latency of 2.8 and an amplitude drop across the elbow from 6.3 to 3, consistent with focal conduction block. The left-sided median study and ulnar motor studies were both normal. The CMAP recorded from FPL was slightly asymmetrical, 4.3 on the right and 6.6 on the left. F waves revealed slight prolongation on the right compared with the left, with reduced persistence. The ulnar F waves were normal, and median somatosensory evoked responses were normal and symmetrical.
So what do you think about that?
Was there any cold paresis?
Cold paresis? Didn't check it in cold.
Was there any proximal conduction block in the other nerves?
No obvious proximal block, but there may well have been. Yeah, but
And
it's,
Con, how much dispersion was there with that conduction block? It looked like it was prolonged.
Yeah, that number's actually incorrect, the duration.
So the duration incorrect?
That's incorrect, yeah. So they're actually similar duration. I measured them out.
if you look at that, it's
No, I just looked at the duration. It looks obviously.
It's not dispersed.
So you sure the APB wasn't weak? Must have been.
Look,
That's a true block. Must have been weak.
depends on how much you lose, Steve. But I wasn't confident there was weakness. But as John was saying, she was moving a lot, so hard to be sure. But I wasn't confident.
Was that the only side of conduction block?
Yeah, it was.
The lower ones, there was no conduction.
No.
Nothing.
So EMG basically just showed, well, this is when she was hand flat, so she was having a little sort of irregular moves. This is recorded from APB. But there's no convincing right finding. It's a question of whether some of those potentials were fasciculations. Yeah. And then when she gets into a sort of strong movement, it's just a burst of EMG activity. So, any comments so far?
And there is an active monofocal neuropathy with conduction block that's been described before. Presumably an autoimmune process similar to multifocal neuropathy. cervical, it'd be interesting to do cervical
I didn't
nerve
do
root
cortical
stimulation or
she's
TMS.
pregnant.
I don't think this is CIDP. Well, it could be motor CIDP, but I don't think it is. And it's not the sort of the typical CIDP because your SSCPs are normal, so you're getting normal 1A afferent conduction through an area of conduction block. So that's what I think it probably is.
Sorry.
Was the burst of EMG activity just in that muscle group, or was it in or was it only in the burst of EMG, was it in that muscle group only, or was it in co-contractors?
Well, I didn't record them simultaneously, so I can't.
Again, just getting away from the dystonia versus the typical muscle.
No, it was only in the group that was contracting at the time. Yeah. Okay. Good. So.
I think we've
So she, we didn't do anything. She didn't want any specific sort of. We didn't do motor cortex stimulation. We didn't do any treatment during her pregnancy, and waited till she had a healthy baby. And about a month or two after she had the baby, she still had the movements, which were still quite severe, and she had gamma globulin.
So did it change in the later bit of pregnancy or immediately postpartum?
The CMAP. Oh, the
Or
movements.
symptomatically?
No, the movements looked the same.
So there was no...
No change. And the nerve conduction studies looked pretty much the same. She had continuous conduction block there. Yep.
Just to go back, did the movements come on gradually and get worse, or were they just?
The impression was that they just happened rather than gradually. Yeah.
So she was commenced on intravenous immunoglobulin, and 3 months into her therapy, this is her video.
Turn your hands around. So it's pretty dramatic sort of improvement in the symptoms. Spread your fingers. And her CMAPs came up quite a lot, so there was no evidence of significant conduction block 3 months later. So
Just have the FPL.
was also quite significant.
Are you saying the conduction block in that forearm segment caused the movements in terms of that was an isolated conduction block, or that there was a more diffuse?
I think that there was an proximal block in the ulnar nerve.
Particularly in terms of the wrist flexion
Yeah.
and analysis and that sort of thing.
And I think we didn't define it because we didn't stimulate proximally enough. Of the nerves. Yeah, we could have imaged the nerve. I mean, it may have shown something, but at the time, I felt confident of the diagnosis, and so I wanted to wait till pregnancy had finished and try her on some treatment. But yeah, I mean, you could have imaged the median nerve.
Did she have any ganglioside antibodies though?
Yeah, they were negative.
They were negative.
Yes. Sorry, Mark.
So, we normally think about heart conduction block and weakness, syndromes with weakness. So, in this particular case, what's your, it looks like a hyperexcitability syndrome.
Yeah.
So, what's your hypothesis as to what's generating the hyperexcitability as opposed to block?
Yeah. Well,
Funny you should ask that question. So we thought we'd briefly just discuss peripheral nerve hyperexcitability in multifocal motor neuropathy. So MMN is predominantly characterised by negative features such as wasting, weakness, depressed reflexes, but positive features are also very common, including cramps. And surprisingly, the pathophysiology remains quite elusive. In 1997, a report was published in Muscle and Nerve of 3 patients with MMN and muscle hypertrophy of very severe biceps muscles, which was associated with cramping and fasciculations. The EMG demonstrated what they described as continuous motor unit activity with frequent fasciculations, and they postulated that the hypertrophy was secondary to the continuous motor unit activity. In the discussion, they talk about the potential mechanism for this and what the potential trigger point might be, and presumably this is distal to the site of conduction block. And they suggested that that these axons at the site of injury are the generators of a spontaneous impulse causing continuous motor unit activity. Subsequently, this paper was published in Brain, and I feel a bit silly summarising it here, but 6 patients with multifocal motor neuropathy associated with focal motor conduction block in the forearm segment of the median nerve were studied with nerve excitability techniques, and it was found that the nerve distal to the site of conduction block was hyperpolarised, and the suggested mechanism for this was that probably the sodium-potassium pump distal to the site of conduction block was overactive, leading to hyperpolarisation. But for this to be constant and ongoing, there would need to be a continuous supply of intraaxonal sodium, which was hypothesised to come from depolarisation at the site of axonal injury. And it was suggested that perhaps juxtaposed lengths of depolarised and hyperpolarised axonal membrane may subsequently lead to ectopic discharges leading to hyperexcitability. I don't know if you want to comment a bit more on that. And just to finish, we have the other case presenting similarly.
You can see it in the middle,
Yeah.
and it's going to go tight, and then it'll start, see?
So it's just the thumb, isn't it?
Yeah. I have had spasms before where the fingers go to the whole hand, makes a claw thing. Gotta fight my hand to keep it straight.
No, not I can see it twitching around.
So it's really hard to show. In the ulnar and median nerve. Her conduction block in the median was in the forearm, but the ulnar was quite high. It was up at Erb's point. So I suspect this girl had proximal block of her ulnar nerve, which we didn't test for because we didn't go sufficiently proximally. I didn't do motor cortex stimulation. She was pregnant. She wasn't 18.
Well, I think it's a very unusual disorder, and what you do see is a lot of this ectopic activity. And I mean, we hypothesise that you make the nerve ischemic somehow through the physical block, and the distal to the block, you get this post-ischemic change. So it's usually, I mean, like if you cross your legs and release leg crossing, you get a lot of ectopic activity. Normals notice it as sensory and motor, but obviously there's a condition here that just affects motor axons for some reason. And one of the hypotheses, as from Angela Vincent, is there is a focal antibody directed against motor axons, against the sodium potassium ATPase. That hasn't yet been discovered. But I think that the ectopic activity is pathognomonic of this particular condition, and I think it's open to anyone to say what the basis of that is.
I guess the importance of showing it is that you don't just get weakness in this condition. So if you see muscle hypertrophy or spasm or irregular movements like that, always think of multifocal motor neuropathy.
We describe the case of hypertrophy with men as well. It's to me that it's more common in the literature to have this topic activity or hypertrophy with men than with
then that probably reflects more that MMN is an axonopathy and a channelopathy rather than a demyelinating process per se.
All right. Caroline?
Sorry. I'm just wondering, when you read about this condition, think about positive and then negative sort of phenomena. Has there been any natural history where they haven't just had treatment and then they've had these positive phenomena and then go on to waste it? Which would indicate that, you know, the conduction block continued and then got worse. And
I mean, that's the interesting thing about both of these cases, is that they did really well with gamma globulin because it was before they actually got to the stage of getting axonal injury.
Yeah, so presumably you're getting this early disease that can be treated easily, more easily than...
Okay, should move on to the next case. There you go.